So first, before I get started, I want to throw this in, given the considerations of all the therapies that have been presented. I think that, we have a grade group sort of differentiation for prostate cancer, but we really need to start thinking about BPH in the same way. So you really have a dichotomous patient population. You have patients who are coming in with bilateral hydronephrosis, renal failure, bladder stones, recurrent UTIs, sepsis, and then you have patients on Flomax with a smaller prostate who want to void with better quality of life. So I think that my plug is going to be that no matter what tool you use, if you are a patient with severe BPH that's really life-threatening, you should have a radical removal of the transition zone, which is driving the disease. Everybody else, you can do whatever you want, as long as they're aware, and then that's where the ejaculatory kind of conversation comes in. So here's my disclosures. So in regards to HOLUP, I just kind of want to give you a brief run, how do you get this started from a very practical standpoint? So you really need to achieve mentored cases. My learning curve was I didn't get comfortable until about, case number 60, and really didn't get confident until about case 100. But there are obviously a lot of people, and learning curves are different. So there are people who've gone to a weekend course who are very talented, come home and they do it on their own, and that's impressive. But that's probably the minority of people. So look to a partner. I would say there's a tremendous amount of really great information on YouTube. Fernando Gomez-Sancha, who has probably the most live video that's sort of complete HOLUP cases. You want to watch from start to finish, so not edited cases. They need to be unedited so you can watch people get themselves out of difficult situations. Everyone can make a very good-looking edited video. Mini fellowships are available for 3 months, and then work with a partner if you have one. I had a partner that came in, and I worked with him for 6 months, and he's doing HOLUP independently now, so it's possible. Patient selection. In the beginning, you want to cherry pick your patients, all right? So you don't want monster glands and you don't want tiny glands, because both are difficult for different reasons. Small glands have bad planes. Big glands require a little bit more kind of understanding of the anatomy and where you are in space. That's the part, that hippocampal visuospatial component is the part that's being trained with repetitions. So, I have this picture of an ice cream cone here. This is that patient with that big, juicy intravesical protrusion, that perfect enucleation patient. Think about that red line there. That's the only part that you have to do a dissection of. You don't need to resect their median lobe. So their median lobe and all that intravesical protrusion is just going to get pushed into the bladder once you release it from the capsular interface. So that's actually a little bit of an easier case. Beware of the flat trigone. When you retroflex and you look back and it's flat, and that's 120 gram prostate, as is this one, that's going to be a very difficult case, because that's a ton of dissection that you have to do, and typically that bladder neck is going to be almost like a skateboard ramp. You're going to have to go backwards on yourself. So these cases, if you study the MRI and study the imaging, you can and study your cysto and cherry pick them, and be prepared to convert to a TURP in the beginning, whatever energy source is convenient for you. So pick like an 80 grammer so you can get it done without bailing. So in terms of scope, pick the one that makes sense to you. So there's 2 considerations. If you're trained with something, just use that, all right, in the beginning. But also think about the fact that these lenses can break frequently. There's a lot of torque on them, and some of the lenses are a little more sensitive than the others. So if you have a hospital system that's got an entire Wolf system, get the Wolf set. If you've got a hospital system that's all Storz, get the Storz set, because those 30-degree Hopkins lenses are going to be interchangeable with your system. So this is just a practical approach, because you don't want to be in the middle of a case and the lens breaks. Now what do you do? Right? There's no backup. I think we've all been there, where you're saying to yourself, this shouldn't be happening. Somebody should have thought of this. But nobody did, and now you're the only one in charge, right? You're the captain of the ship as a surgeon. So, all right, so kind of these are a little bit esoteric differences between the 2 scopes. So if you think about the Storz scope, from the side you can see there's this kind of beveled edge. So in terms of balancing the retraction of the adenoma, it's a little harder, but it's a little more finesse. So you have to kind of balance that adenoma on the very, very tip. And it requires a little bit more rotation. And I think if you want to watch somebody who's really excellent, then watch Dr. Amy Cranbeck's videos that she has, because it looks effortless. But it is a little bit more skill, I think, to learn how to balance it. There's a little bit less accidental blunt dissection, because what you see is what you get with Storz. So you're looking at it, and that's where you're dissecting. There's a lot less sort of blind accidental dissection happening behind you. but it's a little bit harder to master, I think. Wolf, because the lens is further in, there's a little bit more of a beak, and it's circumferentially sort of equal as a circle instead of a bevel tip. You're going to get more contact surface area between the capsule and the adenoma. So what's going to happen is you get in the plane, and it's going to continue to dissect as you move. So that's great. It's going to feel like, look at this beautiful plane, it's peeling away. But just remember, if you're not lasering that interface, you're opening up blood vessels. So you can get a lot of bleeding kind of happening behind you that you have to mop up at the end of the case if you're not careful. So they're both great scopes. So just pick the one that makes sense or the one that you train with and go from there. Camera, there's a little bit of pitfalls here that are kind of funny. You don't want to run into this situation in the middle of a case. So Stryker, a lot of people have a Stryker system. The older ones, 1188, 1288, work great. The 1688, which is one of the newer ones, requires you to have this function called auto light function. You have to have it on, all right? If you use a 13, 14, or 1588, you will have severe disturbance of your image from the high power holmium laser. And if you don't know that in advance, you're going to have a heck of a day if it's your first hole-up trying it out. So you really need to get the equipment straight on these cases. And no one is going to know this because there's no rep for hole-up, right? It's like, it's all a composite of all these different pieces. So the older Storz lens, the HD, is great. I've tried the 4K, that works as well. There's a separate setting as well. The older Wolf is great. You want to use something that's a pendulum or something that's kind of not going to impede your holding it. Just double check it. You know, fire the laser, just double check that whatever you're using is working. In terms of laser, again, I don't sort of beat my chest about it. It's got to be a hole-up. I believe it's enucleation for real disease is kind of where I'm going to die on that hill. So, you know, I think holmium is likely the best energy source. It's got that perfect balance, particularly with the newer generation of holmium lasers, of really just enough peak power to sort of puff open the plane between the transition and the peripheral zone. You get this sort of mechanical dissection from the power of the laser, but then because the pulse width has now been modulated in such a way, and it's usually just stretching the pulse width so it's longer, so if you don't have access to a Moses or a Quanta with virtual basket, any new holmium laser where you can just put it on a wide pulse width will achieve majority of that effect. It's not going to be as good, but its majority of it comes from that. You're going to get hemostasis and a really beautiful plane that's going to open if you're targeting correctly. Of course, that's the other thing. You need to be targeting in the interface. So, you know, next one down, what about pulse thulium? This is sort of a newer kid on the block. It's very interesting. That peak power is about 3,300. So maybe this is the sweet spot. This is going to be something that's going to work well. I know there's some people that have been doing enucleations with this and are pleased. I'm going to trial this in the future. And then you can use a thulium fiber. I mean, people have done enucleations with every single laser that's on the planet. You can use any laser you want, really, but the thulium fiber, I would say, it's going to be a lot of charring. So you're going to be doing a lot of blunt dissection and then mopping up the bleeding as you're going, rather than opening the plane. Morcelator, use the Wolf. Next. Fluid management. Well, it's the best on the market. So until somebody else comes out with something great, you know, I'm not a consultant for Wolf. I'm actually a consultant for Storz. So fluid management, I really like the Thermetic system. You can set the temperature, you can set the pressure. It's easier on the nurses. You go through a lot of fluid with these high flow cases. If you're doing a 300-gram prostate, you know, you're going to go through a lot of 3-liter bags. And every time the bags run out, it decompresses, it starts to bleed. Please change the bags. You don't want to be in that situation. So I think Thermetics is great, and it's easier on the nurses as well. Of course, you can use tandem bags, and it works. You just got to make sure that you talk to your nurse and almost basically have somebody's basically like sitting there looking at the bags. And that's it. I do have a minute for questions.